Hi, everyone, and welcome to the Alliance webinar on cancer research advances based on Alliance's work presented at the American Society of Hematology and the San Antonio Breast Cancer Symposium meetings. My name is Eva Galanis. I'm a medical oncologist at the Mayo Clinic, and it is a privilege to welcome you today in my role as the chair of Alliance for Clinical Trials in Oncology. For the participants who are perhaps not familiar with the group or our work, Alliance is a national cancer clinical trials network. We operate with support from the National Cancer Institute, and we are grateful for this support and partnership over the years. Our work unites more than 25,000 cancer specialists at more than 1,500 sites across the US and Canada, both academic and community-based. Our focus is to improve outcomes for patients with cancer and end cancer as we know it. We do that by bringing scientific advances to the clinical forefront. And along those lines, we also very much value our collaborations with industry as another way to bring breakthrough discoveries to our patients who need it the most. This is the part of our organization that is called Alliance Foundation Trials, and you will hear examples of such studies today. So between our National Cancer Institute funded and industry supported trials, just in the last 6 years, we have treated over 24,000 patients in clinical trials, many of which led to changes in national guidelines and FDA approvals. We are really excited to have you with us today. So without further ado, I will now turn the floor to Dr. Hahn, who is an associate professor of medicine at the University of Chicago and the vice president of Alliance Foundation, and who will moderate the program. Owen, welcome.
Thank you, Dr. Galanis. It is my privilege today to moderate the session. We had the very difficult opportunity to select only 4 abstracts that you'll hear today from the ASH and San Antonio session of all the Alliance abstracts that were presented at these sessions. The 4 that we'll hear from today is Dr. Leitch presenting the surgical outcomes from the alternate study, Dr. Yee presenting a quadruplet therapy in transplant-ineligible multiple myeloma patients, Dr. Metzger presenting the CNS outcomes from our PATINA study, as well as Dr. Wiedewalt presenting an extended follow-up of a regimen in older adults with B-cell ALL. I also want to acknowledge and thank 4 of our Alliance patient advocates who are present today who will be also moderating, Deb Collier, Todd Kennedy, and Julia Mouse, and Lisa Cohen. Their presence and commentary today reminds us of the importance of the work to our patient community, which is the true measure of our success. For our first presentation, I would like to introduce Dr. Marilyn Leitch, who is a professor of surgery at the UT Southwestern Medical Center, who is going to present the surgical outcomes of the alternate study, Alliance 01106. Dr. Leitch?
Good afternoon. I'm delighted to have the opportunity to present what we were able to show at the San Antonio Breast Cancer Symposium. And I'm trying to figure out how to advance my slides here. Here we go. I have no disclosures. So there is little data on the ideal surgical management of breast cancer after neoadjuvant endocrine therapy, particularly with respect to lymph node surgery. In our first endocrine neoadjuvant therapy trial, Z1031, only 1% of patients had no remaining tumor at the time of surgery after they received neoadjuvant endocrine therapy. This is somewhat different than neoadjuvant chemotherapy. So we can't really expect that there'll be a path CR when we do endocrine neoadjuvant therapy, which brings challenges in the surgical management. The alternate trial was a phase 3 clinical trial randomizing postmenopausal women with ER-positive, HER2-negative breast cancer to one of three arms of endocrine therapy. So the three arms were anastrozole, fulvestrant, or the two combined. Patients had a needle biopsy of the breast around 4 weeks after starting the therapies. If the Ki-67 was 10% or less, they continued on the endocrine therapy for a total of 24 weeks. If it was greater than 10, then they were taken off of endocrine to go to either surgery or chemotherapy. At the time of surgery, they were then evaluated for the primary endpoint, which was the modified PEPI score, which if they had a PEPI score of 0, they were destined to do well based on prior data. And so that means that the pathologic T size was 1 to 2, the nodes were negative, and the Ki-67 was less than or equal to 2.7%. For the patients who were non-zero PEPI score, they could then be offered adjuvant chemotherapy and endocrine therapy of the physician's choice, with the endocrine therapy in all arms going for 5 years total. So for the primary endpoint, which was the endocrine sensitivity disease rate, all of the arms were similar with respect to that, and overall, about a 20% rate of that nice PEPI score that would portend an excellent outcome. But pathologic complete responses were very low. Around 1.2% was the highest, 0.5% was the lowest, overall 0.8%. And so overall, the disease sensitivity disease rate was 20.7%. Oops. Sorry. What we're going to be talking about today, though, are the secondary endpoints, but I just want to familiarize you with the trial. And so the surgical outcomes were set out at the beginning as a secondary endpoint. Surgical management was per standard of care, but everyone had to have some type of lymph node surgery, sentinel lymph node biopsy, with or without axillary dissection or axillary dissection, in order to be able to do the PEPI score, which required knowledge of the nodal status. And these are just some characteristics of the patients and their tumors at the start of the trial. T2 tumors accounted for about 3/4 of the cases. Oh, this keeps going on its own. Lobular was overrepresented at 25%. And then there were 300 and, let's see if I can, are we able to move the slide up? I can't do that to show. Well, we had about 383, there we go, 383 people that had lymph node biopsies before treatment, and 33% of those, or 83% of those were positive for metastasis. And the surgeons were required to say what they thought the patient could have for their surgical procedure prior to starting the therapy. And it was about 3/4 of the patients were felt to be eligible for breast-conserving surgery. Only less than 1% were thought to be inoperable. When we look at the actual surgery that was performed for the breast-conserving surgery was performed about 70% of the time, mastectomy 30% of the time. The axillary surgery was sentinel node only in 64.7%, sentinel lymph node plus axillary dissection 20%, and axillary dissection alone at 14.4%. So if we looked at the surgery performed based on what the surgeon said at the outset, if they were felt to be a breast conserving surgery, a breast conserving surgery candidate, still about 21% of those patients ended up with a mastectomy. However, for the people that were thought only to be eligible for mastectomy up front, about 44% of them were able to have breast conserving surgery. And then if we looked at the extent of surgery by the pathologic T stage, as you might expect, the larger the tumor, the greater the chance that the patient would have a mastectomy. With the T3, T4 patients, 64% of them having mastectomy. And then if we looked at the outcomes of the axillary procedures for the sentinel nodes, I don't know why this keeps going, but okay, there we go. For the number of sentinel nodes examined, 2 or more were identified in most of the patients, with only 16% having only 1 sentinel node identified. With respect to the axillary lymph node dissection, the number of nodes examined, most of the patients had more than 10 nodes that were identified in the axillary dissection. And then we looked at surgical management when the positive node was first identified at the time of the sentinel node biopsy. For the patients having breast conserving surgery, about 62% of those had sentinel lymph node biopsy only, while the mastectomy patients, if they had a sentinel lymph node biopsy that was positive, they were more likely to go ahead and have a completion dissection, with nearly 60% of them having the axillary dissection. And then if we looked at surgical management with a positive node identified before neoadjuvant therapy versus at the time of surgery, what we saw is that if they were known to be node positive before neoadjuvant therapy, they were less likely, even with breast conserving surgery, to have sentinel node alone, compared to if they were found to have a positive node at the time of surgery, where it's more about twice that. And then with respect to the patients having mastectomy, only about 18% of those had sentinel node alone if they were known to be positive for metastasis prior to therapy. And then if we look at the surgical management of the axilla when the sentinel lymph nodes were positive, the sentinel node where there were no positive nodes, I'm sorry, I don't know why this keeps doing this, but 3.4% of those patients had an axillary dissection even when they were node negative. If it was 1 sentinel node positive, then 24% of or 39% of those had axillary dissection. And if we get down to 3 or more, then it was highly likely that that axillary dissection would be done. So some of the important observations of the sentinel node biopsy after neoadjuvant endocrine therapy: 382 of the 790 patients had positive sentinel nodes. About 80% had 1 to 2 positive nodes, and 20% had 3 plus positive nodes. In the Z11 trial, there was no benefit of axillary dissection for patients having 1 to 2 positive nodes. But in Z11, all patients had lumpectomy and radiation. So if we looked at the management of the axilla with a positive sentinel node, if there was just 1 positive node in this trial, axillary dissection was omitted in 70% of patients. If there were 2, about 50% omitted axillary dissection, and if 3 or more, then again 50% had omission of axillary dissection. And then if we look at the number of additional positive nodes on axillary dissection, if there was just 1,
I apologize, Dr. Leitch. I'm not quite sure what's happening with the slides,
I
but
don't know
doing my
either.
best to manage now. I apologize.
I'm not even seeing the thing to do now.
You can just let me know
If there
when
was
you're
1
ready.
positive sentinel node, about 57% of the time, there were no additional nodes found on axillary dissection. However, if you get to 2 or 3 or more, nearly 50% of the time, there would be 3 or more positive nodes. So again, in thinking about how to manage that positive node, it's important to know these data. Okay. So with neoadjuvant endocrine therapy, about 70% of the patients were able to have breast-conserving surgery, including 43% who were felt to be only eligible for breast-conserving surgery. I really need to get back to that slide somehow. Okay, there we go. And for surgeons who participate in the alternate trial, the neoadjuvant therapy created new challenges in their decision-making regarding node management, whereas they had a lot of data for what to do in the context of chemotherapy before surgery. But given the low rate of pathologic complete response in the breast due with neoadjuvant endocrine therapy, we couldn't expect to have a pathologic complete response in positive nodes. However, the failure to get a complete pathologic response doesn't have the same prognostic significance as a persistent positive node after neoadjuvant chemotherapy. Based on the procedures that were performed in patients with positive sentinel nodes, it seems that surgeons were applying the Z11 criteria for patients having breast-conserving surgery, but were less likely to omit axillary dissection for lymph node positive patients having a mastectomy. Longer follow-up will be required to assess the local regional recurrence for those who had only sentinel lymph node biopsy after having node-positive disease at diagnosis. If we can get to the next one somehow. So the importance of the alternate trial for patient care, it showed that you can achieve breast conservation for larger breast cancers with endocrine therapy and avoid chemotherapy. We may be able to provide a rationale from this trial to limit axillary surgery even when the person is node positive after neoadjuvant endocrine therapy. And the trial helps to identify features of tumors to define which patients are more likely to respond to endocrine therapy and should be able to avoid chemotherapy as their neoadjuvant intervention. And we want to thank all the patients who participated in this trial. It was quite a large trial with long follow-up, and patients had to do a second biopsy. And so we appreciate that participation, as well as all the investigators and the research staff across the Alliance who participated in the trial. Sorry about the slides.
All right. Well, thank you, Dr. Leitch. And I'm sorry about the technical errors with the slides that as well. So, all right. And so I'm going to turn now to our advocate, Deb Collier, who's been a long-standing Alliance advocate, who's also been very active in the patient advocacy community, who's also worked through the payer network. Deb, this is in this surgical outcomes, we see that 44% of women who were initially deemed to not be eligible for breast conserving surgery were able to ultimately undergo a partial mastectomy, which is a potentially transformative result for patients. From your perspective as an advocate, how do you translate these surgical de-escalating findings for patients? And can you also discuss the role that patient advocates play in the shaping of trial designs in these complex multidisciplinary studies?
Sure, I'll try to in a very short period of time because I know we're running late. Um, this is actually a really important study because, as Dr. Leitch said, we don't know that much about neoendocrine therapy. We know quite a bit about neoadjuvant chemotherapy. And there's a very large percentage of women who are ER positive and who need this type of information. So being able to know more what the parameters are around who can get breast conserving surgery versus a mastectomy is very important. And it does have major factors involved for patients in both directions. And I won't go into any details, but that's a very important one. The other thing to remember is that um, people are who have stage 2 and 3 breast cancer are facing many different treatment discussions or choices, and that has to do with radiation or not, what type of surgery they're going to have, what type of either neoadjuvant or adjuvant treatment. So it gets very complicated very quickly. So the more we can learn about the subtypes of patients on our studies of who does better with this or that will help not only the providers and surgeons figure out what kind of surgery options to discuss with someone, but also help the patients. The real key here is going to be to make the information as clear as possible. So I think we still have work to do in how do we discuss these differences for individual patients so that we can lay out what the options are and then find out what's important for them. We are involved in the development and design of these protocols to try to bring in as many patient factors as possible. So the good news is I don't have a lot of criticisms about how this study was done. We found out a lot of information. Now what we have to do is put it in categories so that it's easier for everyone to explain.
Gotcha. All right. Well, thank you very much, Deb. I think we'll turn to our second presentation. Um, so, so this is Dr. Andrew Yee, who is a clinical director for the Center of Multiple Myeloma at Massachusetts General Hospital, and he is also an assistant professor of medicine at the Harvard Medical Center. He is going to be presenting AFT 41, which is a randomized phase 2 study in transplant-ineligible patients with newly diagnosed multiple myeloma. So Dr. Yee, please take it away. And I think we'll have the slides centrally advanced to avoid any technical difficulties.
Thank you. Thank you. Yeah, thank you for the introduction. And we will be changing gears and talking about newly diagnosed multiple myeloma. So by way of background, the field in newly diagnosed myelomas has transformed significantly over the past years to where treatment has evolved from 2 drugs to 3 drugs to now 4 drugs for newly diagnosed myeloma for both younger transplant-eligible patients as well as for older transplant-ineligible patients, and an established standard is a 4-drug regimen with an anti-CD30 monoclonal antibody, lenalidomide, a proteasome inhibitor, and dexamethasone. So on this slide, I show for the transplant-ineligible patients, the older patients, 2 randomized studies which have established this. These are the IMROZ and the Cepheus studies, and this is with ixazomib or daratumumab as the anti-CD38 monoclonal antibodies. Now, the challenge and the motivation for this clinical trial is the question, does one size fit all? Since the randomized studies for these transplant-ineligible patients, they are essentially taking the exact same regimen for a younger patient and then evaluating it in an older patient population. And is that the best way of going forward? Because I think in oncology, as we all know, we want to tailor the regimen to meet to patient characteristics. Next slide. So the goal of this clinical trial was to develop a regimen for older transplant-ineligible patients who tend to be frailer. And this is using a regimen of daratumumab, lenalidomide, ixazomib, and dexamethasone. A couple key things to point out in this clinical trial is that we reduced the initial dose of lenalidomide from 25 milligrams to 15 milligrams to improve tolerability. That also reflects community practice where we are using a lower dose for older patients. Next is bortezomib is a potential Achilles heel for these regimens in newly diagnosed patients because of the risk of peripheral neuropathy. And in the clinical trial in AFT 41, we used ixazomib, which is an oral proteasome inhibitor. And because it's an oral proteasome inhibitor, it allows extended dosing, right? With bortezomib, you need to come in for the injection. Ixazomib is an oral pill that patients can take on their own. And then secondly, and I probably should have emphasized this, the risk of peripheral neuropathy is significantly less with ixazomib compared to bortezomib. Like peripheral neuropathy is a defining characteristic of adverse event characteristic of bortezomib, and ixazomib does not have that problem. And that's particularly more important for our older patients where they do rely on where peripheral neuropathy can be a more significant factor. So the Alliance Foundation Trial 41 is a multi-center randomized study in older patients that looked at this regimen of daratumumab, lenalidomide, ixazomib, dexamethasone. All patients received this for 12 cycles. And then we compared patients to two arms. One arm received lenalidomide as the standard of care arm, and then the other arm received daratumumab, lenalidomide, and ixazomib. Now, for the purposes of this presentation, we're focusing on the outcomes of induction therapy for the first 12 cycles. Next slide. So again, this is the trial schema, and this includes patients who are older transplant-ineligible patients. And notably, all patients received the same induction regimen, the same 12 cycles of daratumumab, lenalidomide, ixazomib, and dexamethasone. The daratumumab here is a standard dose. Lenalidomide, I mentioned, is reduced from 25 to 15 milligrams. Ixazomib is the standard 4 milligram dose that's given weekly, and we adjusted the dose of dexamethasone based on age. And then there's the randomization is actually done at enrollment. So patients already know which arm they will receive, the maintenance, the control of lenalidomide by itself, or the experimental arm of daratumumab, lenalidomide, and ixazomib. And this is for 2 years of maintenance. Next slide. So these are the baseline characteristics. So I know there's a lot of data presented here, but the couple of points to emphasize is that this is a usual older patient population for multiple myeloma. And just to emphasize, multiple myeloma, the median age of diagnosis is 69. So this is a representative patient population for transplant and eligible populations that's comparable, and maybe a little bit older than some of the randomized studies that we've talked about. Importantly, we also applied the simplified frailty score, which has been presented before, and importantly, about 40% of these patients were frail. Now, something to emphasize in this presentation is that because of COVID-19, this did present some challenges in the accrual. So we were limited in the accrual, and so the presentation, we're focusing not on the randomization part, but for the first induction, the first year of therapy where all patients received the same induction therapy. Next slide. So this is the disposition where we randomized 79 patients, and all 79 patients received the same 12 cycles. And next slide. And the responses seen with this therapy, we showed the majority of patients, over 90% of patients responded, and these were high quality responses. I will point out that the complete response rate here may be lower compared to some of the randomized studies, and I think that has to do with the fact that because we only looked at the first 12 cycles, we didn't get a chance to have confirmatory bone marrow biopsies. So the actual response rate is actually higher. The actual complete response rate is higher because with longer follow-up, you have a chance to have the confirmatory bone marrow biopsies to show complete response. Next slide. And here we show the outcomes after 12 cycles. After the overall 12-month PFS was 92%, and the overall survival was about 94%. And you'll see later, this is comparable to the 4-drug regimens that were just presented in the IMROZ and Cepheus study. But here you can see really excellent progression-free survival and overall survival. Next slide. Now, when we look at outcomes by frailty, I think it's important to point out that if you're frail or non-frail, it didn't make too much of a difference in your progression-free survival in the first 12 months. And it turns out that this is really dominated by age. It turns out in the frailty score, if you're over the age of 80, you automatically are considered frail. And it turns out that the outcomes are really more determined by age rather than frail or non-frail. Next slide. And when you look at the, maybe another click, please. Right, so when you look at the outcomes, you can see that the grade 3 neutropenia rate was about 17%. And notably, the rate of neuropathy was significantly, high-grade neuropathy there's no patients had high-grade neuropathy. Next slide. So how do we put this all together? Because I know when people present these numbers, like these response rates and the PFS, what does that actually mean? Especially if you're not familiar with the myeloma literature. I think what's important to point out is that with this 4-drug regimen, the 12-month outcomes were really comparable to the established 4-drug, these larger phase 3 randomized studies in IMROZ and DARA-RVD. And what's important is that we could achieve the same outcomes as these larger phase 3 randomized studies with using a lower dose of lenalidomide and also replacing the bortezomib with ixazomib. Now, with losing a lower dose of lenalidomide, I think the important finding is that our grade 3 or higher neutropenia rate is significantly lower. And then number 2 is that we have significantly less peripheral neuropathy than compared to these established standards in these larger phase 3 studies. So I think those are the key takeaway points. Next slide. So I wanted to acknowledge in particular the Alliance and the Alliance Foundation mechanism, nursing, the research staff, the investigators, and particularly the patients and their caregivers. I think one of the points to emphasize in this trial was that this was a trial that tried to apply a more patient-friendly approach, which could improve its applicability to our patients in the community who may not have easy access to major medical centers. Thank you.
Thank you, Dr. Yee. And I'd like to encourage you, our audience who has any questions, to please put them in the Q&A box. But now I'd like to turn to Todd Kennedy, who is a longstanding Alliance patient advocate on the myeloma committee, who also has been an advisor on numerous research collaboratives and clinical trials. Todd, from a patient perspective, can you please discuss these clinical trial results and how important is it that clinical trials are specifically designed for and include these older and frailer patient populations, and about the importance of patient advocates playing the role in shaping such designs for these specific patient groups?
Thanks so much, and thanks for including the patient voice in this conversation. I think that this trial is very, very important, and I think it is particularly valuable, as Dr. Yee said, in a community setting too, and because it includes that older patient population. Like Dr. Yee said, The average age at diagnosis for a myeloma patient is 69, but in many of our trials, the average or the median age is 62. And even in the transplant ineligible trials, they skew a little younger than the typical age in that population. So it's really important, as Dr. Yee said, the median age in AFT 41 was 74, and 45.6% were in that 75 plus subgroup, and a lot of these patients were frail. So this is a population where we really need more information on how they respond to various options, and don't just apply what we've seen in some of these pivotal trials. And I think the important thing for those that aren't necessarily following the myeloma space is that, as Dr. Yee said, we have really moved in a major fashion from 3-drug regimens to 4-drug regimens in transplant eligible, but even more recently in transplant ineligible. So I think that standard of care is slowly evolving towards the 4-drug regimen in that older, more frail transplant ineligible population. And so I think that there's still a common use of the old standard of care, which might have been that RVD light, or it might have been a Maya regimen, is what we call it, and that's the DRD. So in that case, in the RVD light, you don't get the anti-CD38. In the DRD, you don't get the Velcade. So can you put these together and get the benefit of the 4 mechanisms? And that's what this trial has done. And I think the findings really present a compelling option by just choosing that oral proteasome inhibitor, Ninlaro, the ixazomib, and then instead of the bortezomib, and then reducing the dose of the lenalidomide. And then you get response rates similar to those phase 3 Cepheus and IMROZ trials, but perhaps with a better tolerability profile, especially regarding the peripheral neuropathy. One thing I love about working with Dr. Yee is he always comes up with really funny things. He's brilliant, but also, and when he said peripheral neuropathy is an Achilles heel, I mean, that was kind of a literal interpretation of the impact of the peripheral neuropathy. And I've certainly experienced that myself, and that is no fun, and that should not be underappreciated in how significant that is. So this is kind of hits that sweet spot of efficacy and tolerability, and I think it's a winner, and I think it's an important option that will be relevant across a broad population. So congratulations and thanks to Dr. Yee, to the investigators, to Alliance, and especially to the patients.
Thanks,
Well,
Todd.
thank you so much for your insights, Todd. All right, I think we'll turn to our third presentation. And this is, I would like to present Dr. Otto Metzger, who is going to present the PATINA study, in particular the CNS outcomes from their phase 3 PATINA study. Dr. Metzger is an Associate Medical Director of the International Strategic Initiatives at the Dana-Farber Cancer Center, as well as an Assistant Professor of Medicine at the Harvard Medical School. Dr. Metzger, please proceed.
Thank you, Olwen. Hi, everyone. Thanks for the invitation. It's very nice to join this panel, and particularly to learn from colleagues from different areas as we get very siloed in our areas. So I have a few slides to talk about the secondary outcomes of the PATINA trial, which is a study that we did through Alliance Foundation over the past almost 10 years now, that basically evaluates the addition of palbociclib for patients with HER2-positive disease in the metastatic setting, in the first-line setting. So given that this is a field that has been evolving a lot, and we know that one of the major problems that we have in HER2-positive disease is that for patients who are dealing with disease recurrence and who have been exposed to multiple lines of therapy, the incidence of CNS metastasis can be high. So we had as a pre-specified secondary outcome in the PATINA trial really to measure the incidence and timing of CNS progression in the study. Can go to the next, please. So briefly, the PATINA is a phase 3 registration clinical trial that randomized 518 patients in the first-line setting. It includes a population that's diagnosed with HER2-positive and estrogen receptor-positive metastatic breast cancer. And patients were randomized after being treated with the classic taxane HP regimen. So patients would have to have this classic period of chemotherapy with the dual HER2 agents, and they would be randomized at that point after 6 to 8 cycles, provided that there was no disease progression, to receive palbociclib with the HER2 agents and endocrine therapy, or the same in the control arm as sort of a maintenance strategy. So the focus here today is this incidence of CNS metastasis, and it's important that PATINA was a pragmatic clinical trial, so we didn't mandate baseline brain MRI to all patients. So this is a limitation to the interpretation of the data that I'm going to show today. Next, please. So here we have the final results of the study. Just to put this into context, we can see that palbociclib, shown here in green, added substantial benefit to these patients. The median progression-free survival was 44 months versus 29 months in the control arm. And this very long median follow-up that we have for the PATINA trial, that's over 50 months of median follow-up, provides us with a good opportunity to look at the cumulative incidence of CNS metastasis, because we know that for many patients with HER2-positive disease, the ability of having the disease controlled in terms of visceral disease provides us a good opportunity to investigate this question to see if palbociclib could have an effect in preventing CNS metastasis. Next, please. The PATINA trial did allow patients who had been diagnosed with CNS metastasis at baseline to be included, but this is rare in the first-line setting, and we had about 20 patients. This slide shows the results, which is the cumulative incidence of CNS progression for all patients included in the study. We can see here in green, in the green curve, that the cumulative incidence of CNS metastasis was smaller when palbociclib was added throughout this very long observation period. So at 36 months, the incidence of CNS progression was close to 14% among patients being treated with palbociclib versus 20.4% in the control, and this was statistically significant. Next, please. So this is showing the same that we have just seen, but it does exclude patients who had a diagnosis of CNS metastasis at baseline. And the reason we're showing this as an exploratory analysis is because for patients who were ever diagnosed with CNS metastasis in the HER2-positive setting, they do have a higher chance of eventually having another lesion in the brain. So by excluding these patients, the idea here is again to try to see whether palbociclib could have an effect in the prevention of the CNS recurrences from ever happening. And here we can see again a nice separation of the curves in favor of the addition of palbociclib. Next, please. So we believe that the addition of palbociclib on this regimen, in the PATINA regimen, was associated with a lower incidence of CNS metastasis. This was statistically significant with a longer follow-up. And this gives us a hint that palbociclib may delay or prevent CNS involvement in this subset of patients. And this is a finding that really warrants validation in subsequent studies. There are many limitations to secondary objectives in clinical trials, and the way this was done, given that we didn't have mandatory images of the brain at baseline. And so, but it does give us a hint for the first time that we could have an agent that's associated with delay or prevention of CNS recurrence in the HER2-positive space. We know that we have many other agents in this space that have activity for patients who have brain metastasis, but this is different. What we're trying to see here is whether by blocking the CDK pathway in HER2-positive disease, if this could have a prevention effect. So this basically opens up a very good research question for future studies that I hope will happen given the importance of this topic to patients. So thank you so much. I think that my next slide is the acknowledgement like a special thank you to Alliance, which is my favorite clinical trial group that I've been involved for many years, and of course to all the patients and families who participated in the clinical trial, and all the staff that made this possible through a global collaboration. Thank you so much.
Right. Thank you, Dr. Metzger. I would like to now turn to our patient advocate, Julia Miles, who is involved with Alliance, but not only that, she has co-founded the advocacy group GRASP, as well as a patient-centered dosing initiative, and has been very much involved with not only Alliance, but ASCO, an advocacy group for Metastatic Breast Cancer Alliance, as well as with the FDA. Julia, the finding that palbociclib can reduce the risk of brain metastasis in HER2 positive, HR positive disease is especially meaningful for patients. And as a patient advocate, what is your perspective on kind of prospectively including endpoints of CNS on brain met prevention in clinical trials? And what does Bettina teach us about this, and how should we be thinking about clinical trial design moving forward?
Thank you. Yeah, it's really great to see this trial presented. I think one of the things that we see patients that are HER2 positive and also have HR positive disease, they often felt like the hormone part of their cancer was not explored in treatment as often. So Petrina really allowed them to access this CDK drug and then now seeing the effect that it has on CNS metastasis, which is unfortunately one of the big concerns for this subtype, which often goes to CNS. So no, this was very encouraging for patients with HER2 positive breast cancer.
Excellent. Right. Thank you so much for your perspective. All right, so we will turn to our fourth and last presentation. We're going to end with a leukemia note. We'll turn back to our heme colleagues. So this is Dr. Matthew Wiedewald is going to present the extended follow-up from the Alliance A04-1703 in B-cell acute leukemia patients. Dr. Wiedewald is a professor of medicine at Wake Forest University School of Medicine. So, Dr. Wiedewald.
Thank you, Dr. Hahn. So when we think about treatment of older patients with newly diagnosed Philadelphia chromosome negative B-cell ALL, they have a traditionally dismal outcome with overall survival of less than 20% at 3 to 5 years with the use of traditional chemotherapy. So this is traditional cytotoxic chemotherapy. And that's due to a combination of, unlike in younger patients, the high risk of non-relapse mortality, so death from toxicity of treatment, of early death in induction, as well as high relapse rates due to inability to complete chemo, as well as higher risk cytogenetic findings. So the idea of this study was, when two new targeted drugs came along, is just eliminate chemotherapy, conventional chemotherapy entirely, as it had basically failed in this patient population, similar to how it failed in Ph positive disease, where we are now using chemotherapy-free treatment for basically all adults diagnosed with Philadelphia chromosome positive ALL. This study focuses on Philadelphia chromosome negative ALL. The rational use of targeted therapies may be more effective and much less toxic through the reduction or elimination of conventional chemotherapy, and holding that outcomes from this study, as older patients have done poorly with Ph negative B-cell ALL, may inform treatment of younger adults and even pediatric patients diagnosed with B-cell ALL. The background is that the anti-CD22 antibody drug conjugate, inotuzumab ozagamycin, and the anti-CD19, CD3 T-cell engaging antibody blinatumomab were both superior to conventional chemotherapy in phase 3 studies in relapse refractory B-cell ALL. And characteristically, inotuzumab ozagamycin induces high remission rates in untreated and relapse refractory B-cell ALL, And blinatumomab can induce durable remissions in low burden disease, basically increasing cure rates in the front line in pH negative B cell ALL. Next slide. This was the schema for the treatment. Basically, inotuzumab zagamycin was given alone. It's standard dosing used in relapse refractory disease for 1 cycle, followed by response assessment. Patients that showed disease response were given another cycle of inotuzumab zagamycin. Patients that were refractory to the first cycle of inotuzumab zagamycin moved on to blinatumomab therapy. With blinatumomab therapy, patients got 2 cycles of treatment. That's 4 weeks on, 2 weeks off, followed by response assessment. For patients that were in a complete remission, they continued on to receive either 2 more or 3 more cycles of blinatumomab based on their response to inotuzumab zagamycin. Any patient that was refractory or relapsed at that point went off study for alternative treatment. And in all acute lymphoblastic leukemia, we give intrathecal chemotherapy by lumbar puncture to prevent CNS relapse. For this study, we used 8 doses of intrathecal methotrexate. Next slide. So the objective of this report was to evaluate outcomes of the regimen with extended follow-up at a median of 45 months. This was a follow-up to a previous report and publication that addressed the primary endpoint of 12-month event-free survival. These were the patient characteristics. The median age was one of the older studies, maybe the second oldest study reported in B-cell ALL, with a median age of 71 and a range of 60 to 84. Eligibility was 60 years and up, with over 52% of the patients over the age of 70 years. 85% of patients were white. The majority were non-Hispanic at 82%, with 9% Hispanic or Latino. 58% were male. 58% had a performance status of 1 by ECOG. Notably in this study, unlike most studies in B-cell ALL and other malignancies, prior malignancy was allowed as long as it was in remission for 2 years. So prior malignancies treated with chemo and or XRT included 8 patients, or a quarter of the patient population, and 6 of those patients, or 18%, had prior multiple myeloma. Presenting white count was 3.2, with CD22 expression on 92% of the lymphoblasts at the time of diagnosis, being the median. This is the event-free survival with 45 months of median follow-up. Events for this study were refractoriness to treatment, morphologic relapse, or death. The 3-year event-free survival was 48%, and with a median event-free survival of 31 months. In the initial analysis, that met our predetermined historical event-free survival at 1 year was 10%, estimated 10 to 20%. At 1 year, it was clearly superior, and it continued to be superior out to 3 years to historical outcomes. The events that we saw, not surprisingly, this is an extremely tolerable regimen. There were 3 non-relapse mortality deaths. 1 was treatment-related mortality on therapy. 1 was a mortality after a bone marrow transplant, and 1 death from relapse of multiple myeloma that unfortunately the patient succumbed to. The other 12 events were relapses with 1 induction death in addition. Relapse, notably, these drugs target CD19 on the surface of the cells, of the leukemia cells, as well as CD22. So 4 of the relapses had lost CD19 expression on the surface, so there was probably a subclone present that was not treated by the blinatumomab. And 6 patients were CD19 positive relapses. There were no isolated central nervous system relapses, which is promising and maybe a little bit surprising compared to experience with Philadelphia chromosome positive ALL, but states that our intrathecal prophylaxis appears to be sufficient to prevent CNS isolated CNS relapse. Event-free survival was worse in univariate analysis with lower CD22 expression, less than 90%. and MRD positive EDT after course 1A, that initial inotuzumab induction treatment. But in fact, any MRD positivity at any point in therapy was associated with a worse event-free survival. As far as overall survival, with again 45 months of median follow-up, the 3-year overall survival was 59%, which is far, far above what we see in older patients of about 10 to 20% 3-year overall survival with conventional chemotherapy alone. And median overall survival had not been reached at the time of this presentation. Comparing it to other regimens, and I'll briefly go over these regimens. Our regimen 04-1703 was inotuzumab followed by blinatumomab without conventional chemotherapy. 3 other studies used inotuzumab with or without chemotherapy and induction, followed by chemotherapy. The age was oldest in our study at 71, and other studies of similar age were 68 and 68 median. Notably, the overall survival in our population compared to our study compared to those was superior at 59%. Cumulative incidence of relapse was similar between INO chemo, and cumulative incidence of non-relapse mortality was substantially lower than some of the studies and lower than all the studies at 3 years, 9% of patients. So there were 3 deaths, as I've already highlighted, due to non-relapse mortality. This was compared to up to 33% basically treatment-related mortality or non-relapse mortality seen in the MD Anderson experience incorporating inotuzumab with chemo both in induction and consolidation. So this is an incredibly safe relative regimen. In addition, the regimen duration is about 7 months versus the other regimens where the duration of therapy is 2 to 2.5 years in older patients. So the conclusions is with longer follow-up, remissions and survival on treatment on the A04-1703 regimen of inotuzumab followed by blinatumomab alone appeared durable. The regimen has similar 3-year event-free survival and overall survival to regimens combining inotuzumab dasagamycin with chemotherapy in older adults with Ph-negative B-cell ALL with a low non-relapse mortality. And that randomized study is needed to evaluate the benefit of any of the addition of chemotherapy to inotuzumab dasagamycin and blinatumomab. And the Alliance is developing a study looking at that question, a randomized study looking at inotuzumab dasagamycin and blinatumomab versus inotuzumab dasagamycin, blinatumomab, and chemotherapy to see if there's any additional benefit of chemotherapy in this patient population. And with that, I'd like to acknowledge everybody who has helped on this project and the cooperative group, the Alliance and the cooperative groups, and especially, next slide, and especially patients and enrolling physicians who took a chance on a novel approach, eliminating conventional chemotherapy based on what we knew about these 2 drugs at the time, and ended up contributing to what many think is an advancement in the treatment of older ALL and hopefully of younger adult and even pediatric ALL.
Excellent. Thank you, Dr. Weirwald. All right, I was going to now turn to our advocate, Lisa Cohen, who not only is one of our Alliance advocates, but has also worked with the Leukemia Committee for ASCO. And Lisa, could you please comment on this study as another theme with our prior heme multiple myeloma study continues on the theme of focusing on an older patient population that is often overlooked in our clinical trials. Could you maybe discuss a little bit about how important it is to continue to focus on this patient population and how cooperative groups are well poised to do so?
Yes, I can. First of all, I want to say this is such an exciting trial. When we're looking at, an average patient population in this trial of 71 years old, the toxic load has a huge, with traditional chemo and the standard therapies, has a huge effect on the quality of life of this patient population, especially, at 71 years old and older, there's a lot of vulnerabilities. So I think this is very exciting in terms of comparison to previous standard therapies when you're looking at durable survival and remission for this group. So the fact that it's a event-free survival for 3 years of 48% and an overall survival of 59%, when using this, non-chemotherapy regimen versus previous chemotherapy regimens with less than 20% of 3 to 5 year survival, it's very exciting. And the shorter treatment duration is also important for a quality of life, especially in an older patient population. I will say the blinatumomab does require this continuous IV administration, which can be burdensome for any patient population, really. And so I do think it's important as advocates when we look at patient education material to be clear about what this group, what you're going to be signing up for in terms of managing this external port, et cetera. And then the other piece is how can we make this more accessible to a broader patient population with this administration of continuous IV. So I look forward to seeing how the next 2 cohorts of this trial really address a younger population and then the positive B-cell ALL.
Thank you. Excellent points about accessibility for our patients. So thank you so much. All right. Well, thank you. I really want to thank all of our presenters and study chairs, as well as our patient advocates. And I think your commentary really does remind us why this work matters. Many thanks to everyone who attended. If you please have a few seconds, if you can take a look at this QR code and give us some feedback. I also want to acknowledge that all of this work is really possible to a collective effort of so many people. This is the collective effort of our Alliance scientific leaders, our Alliance staff, our statistical and data management program, our larger NCT and member institutions, their investigators, their research staff, the thousands of patients that enroll in the Alliance and NCT and trials, all of the patient advocates, our NCI who sponsors our grant, as well as our industry collaborators. We really thank everybody who makes all of this work possible. And so on behalf of myself and Dr. Galanis, many thanks for joining us today, and we look forward to seeing you at our May group meeting and our future Alliance programs. So thank you, and Dr. Galanis, I'll turn it to you if you want to say any parting words.
Thank you very much. We greatly appreciate your attending and the amazing work showcased today. Looking forward to the next steps, and the studies create a foundation we plan to explore further for the benefit of our patients. So looking forward to seeing many of you in person in our May Alliance meeting. Thank you again.
Thank you, everyone. I appreciate everybody's time.